be joining in a minute. Okay, the next presentation is going to be by Ingvild Almås Tillmann von Carnap, speaking on the microeconomics of pandemics in developing countries and application to Uganda. Thank you again, for coming. It's great to have you. Same rules apply in a 20-25 minutes, presentation, allowing enough time, for discussions. The floor is yours. Thank you.
Thank
I guess Tillmann is going to go first, I guess.
Yeah, exactly. Thank you very much, Christos, and thanks again for the invitation. So my name is Tillmann. I'm a graduate student at the Institute for International Economic Studies in Stockholm, and I'll be presenting our work for this research group together with Ingvild, who's going to come in a bit later. So our study here really is motivated by the observation that as the coronavirus spread, the lockdowns that were imposed across countries were really quite severe everywhere. So on this graph, you see the Oxford Stringency Index that we've already seen in various shapes and forms before today, across World Bank income groups. And as you can see, in mid-March, lockdowns were imposed across the world, and particularly strict in low-income and lower middle-income countries. As a case in point, the country we are focusing on here as an example of a developing country, Uganda, had one of the strictest lockdowns across the world, according to this measure. And so economic models, and particularly ones that came out relatively early, justified these restrictions. So they said that from a social planner perspective, that trades off the utility of the living against the cost of dying, it may be socially optimal to impose very strict lockdowns that restrict economic activity in order to save lives. However, in developing countries, there's now emerging evidence that these lockdowns, perhaps unsurprisingly, inflict a lot of economic hardship on the population. So for example, Mahmoud and Riley in Western Uganda, in a recent publication, show that in their sample of rural households, half the people, all the households had already used up half of their savings, and basically the whole non-farm employment opportunities had dried up. So these employment outside of the farm are usually an important source of income and of smoothing agricultural periods, but these opportunities completely disappeared. And so evidence like this and considerations around different risks between countries have led development economists to be rather critical of the chosen policies, arguing that on the one hand, which at the time was perhaps more of a hope that the virus would be less dangerous in African countries due to their younger populations, but also highlighting this trade-off that in a developing country, people may have not a lot of room to adjust their economic activity and will be quickly put between a rock and a hard place. And so these observations motivate the two projects that we've been working on within this group over the last months. First, I will present just very shortly about as a sort of teaser, and happy to talk more about it later, and focusing on the second one. So the first input we wanted to give to this discussion is to see how can we think about, how can we get to a number that tells us how risky the disease really is across countries, given their demographics and given their health system. And the second one would be looking at, well, given these differences between countries, should these welfare optimizing policies that seem to suggest lockdowns in rich countries, do they also suggest similarly strict policies in developing countries? And so as the first project, the first part, how can we construct such a number that tells us how many people are going to die or are likely to die once they have contracted the virus? And this is difficult in all countries because we don't know the true number of people that would be infected, and we don't know that are infected and the true number of people that die of it, and we may never know. So our approach here relies on medical data from high-income countries, in particular from France and Italy, and accounts for some of the main differences between rich and poor countries. So one very salient difference is, of course, the age structure. A different one, which is particularly relevant in the case of COVID, are comorbidities and, of course, health system capacities. So then our approach uses a simple application of Bayes' rule, where we say that we can calculate the probability of dying if we know the person's comorbidity status, her age and her gender, conditional on infection. If we know about that person also, what is the probability of dying in general once you have an infection? So that's the term on the right, furthest on the right here. If we know the probability of having a comorbidity when people die, and the probability of comorbidities across the population in general. So taking these probabilities on the right from medical studies in Western Europe, we can calculate this probability, this conditional probability for a given age group and a given gender distribution, and then apply actual data from developing countries to aggregate up these figures into an IFR for these countries. And our results are shown on this map here, which highlights, with darker colors indicating a higher mortality risk, and highlights that, according to our calculations, the main risk is really in countries with relatively old populations and relatively weak health systems, such as in Eastern Europe and in the Caribbean. And in African countries, the risk is substantially lower according to our calculations, but perhaps not as low as one could have hoped for, or that perhaps the image that that early opinions about this portrait. So as a case in point, our estimates for Uganda are about half as large as the estimates for the US, so a lot smaller, but not nothing, definitely not nothing. And so given these differences in mortalities, another very salient difference, or the defining differences between developing and developed countries is, of course, their income. And so we want to see whether welfare optimizing policies through the lens of economic models differ across contexts that are characterized by these differences. And here we build on a recent paper by Eichenbaum, Rebello, and Trabant, who focus on the socially optimal policy in the United States. Our contribution here consists of extending their model to better reflect some of the salient features in developing countries and to calibrate it to the case of Uganda, where we take Uganda because it's a good example of these two differences. It has one of the youngest populations in the world, and it's also one of the countries with the lowest incomes. And in a small extension that I will show later, we also we allow for the introduction of a vaccine, or the expectation of a vaccine to arrive, which is also a difference between rich and poor countries, as poor countries may have later access to these vaccines. Now, really a key consideration that you may have thought of already for these kind of models and calculations is the value you put on a life. So you could have a social planner in mind who wants to minimize all deaths at all costs, or you could have one in mind that that weighs off or that balances off these two costs. So while we have to take a stance on this in our calibration, Ingvild is going to later talk about a bit how we think about what is a good choice here and what should perhaps be a focus of research going forward in getting to these numbers. So let me give you some details about the model we're using. The ERT model, our main reference, combines epidemic and economic components, where the epidemic part is maybe something many of you will have heard of over the last week, the SIR model. The SIR model is from epidemiology, compartmentalizing the population into susceptible, infected, and recovered, and assigning certain probabilities to transitioning between these two states, where the base are these three states, where the basic intuition is that the more people that are infected, the more people they can infect among the susceptible. But at some point, there are so many people that are recovered and have acquired immunity that the epidemic dies off because people recover faster from the epidemic than new people can get infected, and herd immunity is achieved. I will come back to this later. And with a small extension, you can also include the probability of dying. So that's the IFR numbers we calculated before. Now, if you want to combine such a model with economics, you can follow the approach that ERT use and that we adopt here, where they say, well, new infections don't just come about because people pop into each other randomly, but it's because people take choices about their economic activity. So they can take choices about how much they want to work or how much they want to consume. And so in this framework that we use, some share of the new infections come from consuming, some share comes from working, and some still come from random interactions. And in choosing these shares, we rely on evidence from previous epidemics of the flu or influenza waves, where it was shown that about a third of infections comes from these economic activities, and about 2/3 of infections comes from interactions within the household or interactions outside of economic activity. And so where does economic behavior come in here, or economic optimization? The model has a representative agent that trades off or that wants to consume more and doesn't like to work for it, but has to work for it. And this agent strongly dislikes or cannot have his consumption fall below a certain subsistence level. We argue that these subsistence levels are really something that is particularly important for analyzing developing countries. And when agents make their choices about how much to consume and how much to work, they realize that when they are susceptible, there is a probability, tau t, that they end up being infected, indexed by the I here. So that in the next period, they will have a lower utility because they are infected. And they also understand that this probability tau is related to their own consumption choices and the consumption choices of the infected. So if they decrease their own consumption, they can reduce their own exposure to getting infected. If they are infected, they may either recover with this probability pi r here, or they may die, and this incurs a societal cost. And so this idea that people realize themselves that when they expose themselves to the epidemic, they may get sick, is really, even without the government doing anything, is really a nice observation that some of the Google mobility data that we saw before highlights that in some countries where there hadn't even been a lockdown yet, people had already reduced walking around and going to places, suggesting that this mechanism of me adjusting my behavior, even without someone telling me to, can have some power. But in this framework, there's still a role to play for the government, because agents don't realize that when they are infected themselves, they could still infect others. So the government does have a role to play here. And the way the government is modeled here is that it sets a containment rate. So a containment rate targeted at consumption. Saying it's modeled here like a tax. So it's saying all the measures that the government can do to discourage consumption. It's not actually taking away resources from people, it just makes it more costly to consume, where the idea is that if it makes it more costly to consume, you're going to consume less. And so the question we are asking in the model that I will show in a second is, what is the time path of this containment variable mu c here that maximizes aggregate utility? What's the time path and what's the incidence? And in our analysis, we contrast two settings, the United States and Uganda, where for the United States, we basically take the same values as our main reference. And for Uganda, we pick values that are in line with household surveys on average incomes per year, on hours worked, on the lowest incomes that people survive on, and we take our estimates of the IFR. And as I said, a key point you have to make is the value of a statistical life, where we here for our benchmark calibration pick a value that accounts for differences in GDP per capita between the countries and for differences in health spending. So which we take as a possible revelation of how much the government values keeping people alive. So let's have a look at our calibration to the US as a benchmark, which is mostly an adaptation of previous work. In black, you have the pure SIR model, so that's only epidemics and no behavioral adjustment and no economics. And you can see that the epidemic spreads until at some point 7% of the population are infected. But at that point, so many people have already acquired immunity that the epidemic slowly dies out. And at the end of the model, 60% of the population have ever had the disease, which is something we target in this model. It's not a function of the epidemic itself, but for the purposes of the model, this is the amount we target. And since in this very simple model, there is no way, apart from herd immunity, for the epidemic to stop, there is some fraction at which you would optimally want to land for the number of people that have ever gotten the disease. So that's this herd immunity level line here. Ideally, if the government, if there's no way to just eradicate the virus, if you just want to let it spread slowly, the best the government can do is to press down the number of people that ever got the disease to this line. And so if we now introduce, and so this is sort of a reference point for how powerful a mechanism can be. So if we now look at what happens when we introduce economic adjustments, in the solid blue line here, we have the model where the government doesn't do anything, but people realize their infection risk. And in calibrating the model to the US, this reduces consumption, or agents voluntarily reduce their consumption substantially, to like something like 8% over the first year. And this helps to control the disease. So people get, the peak infection is lower, it extends the duration of the epidemic, but in total, less people ever get infected and less people die. Now, when we introduce the government, so when we ask what should the government optimally do, then we see that in the US, it's really warranted from this model's point of view to have a strict lockdown that follows the time path of infections, arguing that this externality that comes from agents not realizing their own infectiousness is highest the more people are infected. And in total, this leads to a substantial reduction in consumption, which is our measure of GDP here. So this is something like 25 or 20% of recession over the first year of the epidemic. But again, this is pretty successful in reducing deaths, as you see down here, reducing deaths by about a third in total relative to the basic SIR model. Now, what happens if we compare this scenario to our Ugandan calibration? That's what you see here in orange. So perhaps let me first point out the different lines here in the deaths panel. Because we have a different IFR calculated for Uganda, the pure SIR model already predicts a lower death share in Uganda per se, but we are interested in how much policy and consumer behavior affects this difference between the lines, between the different models. So let's have a look up here at aggregate consumption, at the voluntary consumption reduction that agents have. This is, as you can see, much lower in Uganda. So Ugandans, or the agents modeled as being Ugandans here, would voluntarily reduce their consumption much less than Americans, and thereby the epidemic is slowed much less. Why is that? Well, Ugandans are modeled to be relatively close to their subsistence level compared to the US. So for them and their deliberation of how much to reduce their consumption, it really would hurt them a lot to reduce their consumption substantially, and that's not what they would optimally do. And similarly, for the role of the government of the optimal policy, it's much less strict than in the US. It does not extend the duration of the epidemic as much, and the incidence in total is much smaller, something like 5%, a 5% recession over the first year. So given our parameter choices, this suggests that optimally the government in Uganda would not choose to impose an as strict recession as the US government has done. So let me sum up these steps and show them to you maybe in a different format that's easier to compare. So in this graph you have at the top, this graph shows different runs of our model with different calibrations, where at the top you have the reductions in deaths by either the voluntary adjustment or the containment policy relative to the SIR model. So that's about how much does optimal policy want to reduce deaths. And this part is about the consumption reduction that agents experience in the first year. So this is basically comparing these two graphs is about how much consumption reduction do I want to accept for saving this many lives. And as you can see, as we move from column 1 here, which is the first graph we looked at, so the US calibration, to column 5, which is the Ugandan calibration, this goes down a lot. So the same social planner, the same setup in Uganda generates a very different prediction about what's the optimal social policy. And the things that matter here are both the IFR. So between these two columns, the only thing that changes is a much lower IFR for Uganda. This already makes the disease less dangerous, so less costly in terms of deaths. So it's more costly to avert one more death. And the same, and similarly, if we only change the economic part of the model, so calibrate it to the lower incomes in Uganda, this gives us a similarly sized reduction in the optimal recession that the agent wants to, that the social planner wants to induce. Now, this stands in this result that it would be much less optimal in developing countries to have these strict lockdowns stands in contrast with what we've seen on the first graph. So it looked like countries all over the world decided to have a strict lockdown. And one reason they may have done that is because they wanted to buy time. So there was I remember, especially in the early weeks or months of the pandemic, there was a lot of talk about when the vaccine is going to arrive and so on. So it could be that countries simply want to buy time. And we can look at how optimal policy changes under such a scenario within our model. So what's going to happen now is that we allow for the probability of a vaccine to arrive, where the assumption is that once a vaccine is there, the government can just apply it to everyone, and people can, and people no longer have to be infected to become immune. So the way it's modeled is basically that agents now expect that in every period a vaccine becomes available, and therefore adjust their actions. So this is the same kind of graphs as before, just leaving out some of the epidemiological details. If we first focus at the US case, if the government expects a vaccine to arrive within a year, then it may be optimal to be very strict in your lockdown from the very start. Through that, you delay the epidemic a lot, you decrease the incidence a lot, and you Yeah, sorry, that's what I wanted to say. So you control the epidemic very early because you think that at some point in the relatively near future, you can end the epidemic at a cost that doesn't have at low economic cost. But again, the case in a developing country is very different. So for our main Ugandan calibration here in orange, it's much less, it's not the case that waiting for a vaccine justifies a very strict lockdown early. Why is that? Because for an Ugandan, it doesn't matter whether the lockdown is because you're waiting for a vaccine or not. The loss that you incur comes, the loss that you incur from economic restrictions bites a lot already early. And if we think about the likely scenario that vaccines would become available even later for developing countries, because it may be difficult for countries to have access, or because it will be difficult to roll it out, then waiting for the vaccine to arrive and not going for a quick herd immunity scenario becomes even less attractive. So the longer you think it takes for the vaccine to arrive, the more your optimal policy looks like the case where you don't have a vaccine coming at all. So as you may have already realized during these discussions, the key feature here is how we think about the values of lives against deaths in general. And there we'll hand over to Ingvild for the following sets of slides.
Yeah, so we just wanted to also mention where we stand in some sense. So this is where we really work now to try to think about this valuation of life. And it really matters here, as I will show on the next slide, how exactly you think about that. In the model we just showed, in the ERT model, and also the one, an assumption we adopt is that the valuation of life is the lost utility of those dying. So it's sort of the lost utility of those years they would have lived without dying. And in order to sort of, so we think it would be nice to target that valuation to something that we observe, okay? And for the US, a natural thing we think that also the Eichenbaum et al. Do is to target 9.3 million, because that's an implicit valuation that is in the American system. I mean, it varies a bit, these numbers, from 9.7 and 9.6, 9.3, but they target this number, and this is something we adopt. And then the question, of course, is how should we scale this valuation of life in the US to some number in Uganda that makes sense? And one way of thinking about it, of course, is that we can observe what kind of trade-offs local governments are making, right? So, and this is not a new idea, of course, but looking at cost-benefit analysis from road building, for example, how much more are you willing, if you will build a road anyway, how much more are you willing to pay to save an extra life by securing that road, right? So that's an implicit valuation of life that governments across the world would be making when they build roads, either explicitly or implicitly. And it seemed natural to target such a number. So target something we observe as a revealed preference in Uganda then. And the way we've done this so far, there are different candidates here and people have done different things. So what Tillmann has shown so far would be that we scale it to the health spending in Uganda relative to the health spending in the US. And he showed the formula why it's sort of, it's reduced to that. So that's a way of thinking about how much do they value to save lives versus consumption in Uganda relative to in the US. Another candidate, of course, would be to scale to income or GDP per capita, PPP adjusted. So you could use GDP, you could use GNI, you could use also the incomes we are using in our own calibration for Uganda and the US. Or you could use sort of a 0.8 factor as an exponential, which has also been used. And it's a bit hand-wavy what I'm saying now, because we haven't really landed this, and we're working on sort of looking at the implication of different valuations, and we're still trying to think about the most reasonable way of actually finding this target. So of course, this is part of why we present this, is that maybe we have some interesting discussions at some point with you. Either, I don't think there's time now, unfortunately, but at some point later. But can you just go to the next slide, Tillmann? I think there's the graph which shows that this is not sort of, it's actually something that matters how you do this. So if you just look before the dashed line, the dashed vertical line, that's what Tillmann already showed you. Then if you instead use either scaling to GNI or scaling to our incomes in Uganda, then you get these different numbers. So the first column would show then just scaling it to our income, and it's a proportional scaling. It's not obvious, right, that this is homothetic, that life is sort of a homothetic good. It's not obvious at all to us, but this is at least one way that has been used in the literature, and then you can scale it also to GNI, which is the second column after the dashed line. Okay, so then I think you can just go to the conclusions. We have spent more time than we have already. So let me just, yeah. So this is just a conclusion, but let's not spend time on it. We've said it all. So we have these IFR estimates that we base on comorbidity, age, and health system that we feed into this macro modeling approach. We have this simple framework, and then we extend it to fit better a developing country case. So, and where we're working right now is in progress is this, how you value a life lost or a year of a life lost. So thank you all.
Well, thank you both. I mean, this is fascinating again, and highly topical. We've got a few questions now coming through the chat box. So let me go through those. David is asking, why do Argentina, Russia, and Ukraine have the highest risk on the map, like you showed?
So I would have to go back to the calculation for these particular countries, but my intuition is that, or what we looked at for these country groups in general, is that Eastern Europe has a particularly disadvantageous demographic in terms of having a high share of old people and a high number of comorbidities in this group. And without knowing for sure, and a relatively weak health system for many countries there, and without knowing for sure, I imagine it's a similar factor driving it in Argentina.
David, are you will come back to that? Or?
You are still muted.
Maybe you have to help him. Is he shut out? Or no? No, there he is.
Yeah, he's unmuted. David.
Okay, so you can hear it. Yeah, that's my fine. I'm skeptical that Argentina is going to have more comorbidities. I guess one of the things that it's an issue in my own paper too, but I'll pass the buck to you guys, is, HIV. I would not want to have HIV and COVID at the same time. And yet I'm looking at these, I can't exactly see, is it Namibia or Botswana down there? You'd think that they have either be terrible impacts of comorbidities. I guess the other thing too is we really have no idea how bad these various comorbidities are yet. And I know you have to make a picture based on what you have so far, but I just there's malaria and there's HIV. I mean, we just kind of don't, there's not even enough deaths yet to draw inferences about that. I mean, is that
right?
Is that your guys' view too?
Yes, so I think you're completely right. I mean, we lack data to know this exactly, and it's something we're working on. These joint distributions of comorbidities are important, right? So in our calculations, it's actually having no comorbidity or having one or more. And this is something we're actually talking to the Swedish public health authorities, because in Sweden you actually had, unfortunately, quite a few deaths and they have this individual data, which we may be able to actually find, at least for Sweden. It won't solve all these questions you have, obviously, but that's one thing we are really looking into, trying to get more information from those individual data.
Yeah, okay.
Thank you. Hazel is asking, have you taken into consideration potential for indirect deaths from non-COVID illnesses caused by lack of access to treatment, as health centers becoming overwhelmed by COVID cases?
I think that's a great question, and I think you can extend it even for not just deaths coming from non-COVID illnesses, but deaths from lower consumption or lower health, just poverty. We don't have that in the model at the moment. My sense is that it would only amplify these differences that we highlight, because because now the big cost is dying compared to a loss from lower consumption. But if we incorporate that this lower consumption may actually also have fatal consequences, then this trade-off becomes less clear between that you only want to avoid COVID deaths. So that's definitely something we want to look at in the future.
Thank you. Next is Stanley, who's asking, there are deaths from recession, which you need to take into account also.
Yeah, I think that's exactly the point we would like to.
So that's another thing I didn't mention in the end. One thing we would like to look more into, and in our sense now, is that would actually go in the same direction qualitatively as what we already showed you, that the closer to subsistence you are, the more other deaths you could get from reducing consumption even more, and also reducing access to health system, which some of these lockdowns would do. And that seems to us that it would be more severe in Uganda than in the US, which would also drag actually these optimal lockdowns in the direction of being less strict than in the US.
And I guess at some point, I guess you can push the argument for inequality as well. I mean, you can, because now you're calibrating to aggregates, but I guess at some point, okay, you should be able to get into the life cycle profiles and see how people along the cycle get affected by the disease.
Yes, so Tillmann, maybe you want to. I mean, you.
Yeah, that's also something we were looking at, whether. What different demographic profiles within a country, what role they may play apart from the infection fatality ratio.
Yeah, very interesting. And I guess I missed that. Okay, Ghislaine is asking why not take into account a bunch of countries similar to Uganda in other aspects in addition to your index, and take an average of the measurements in your calibration, like considering the US alone.
Right. I think, in general, our approach here we could easily target it to a group of countries, which is also what other authors have done, or to all countries separately, and show these different results. I think for now we have tried to sort of show two extreme examples: one that is obviously well studied in the US, and one that is in many ways a good example of a developing country. But in general, there's no reason not to, or there's no conceptual reason to not do it for all countries. That's of great interest.
Back to David, last one. David, would you like to ask a question yourself? Oh, of course I can. Sorry. Oh. Sean, can we? Yeah, he's unmuted now. Yeah.
Okay, thanks. So I'm glad you guys did as you'll see, we kind of sidestepped the important issue of the value of a life. So I just want to highlight work that my co-authors Mitch Van Buren and Minky Kim are working on that kind of came out of this very issue, and we were grappling with these issues. One of the things that seems to be true is that mining wage premium are really not that different across countries. And so it's kind of widely agreed that people go into mining even though they're going to risk death because they get paid more for that. And so that's a very direct measure of how much people are willing to risk their life. The fact that that's roughly the same in percentage terms across countries suggests this kind of proportionality with average consumption. As opposed to a world where somebody in West Virginia and South Africa just says, unless I get $1 million in level to go into mining and present value, I will not go in. That doesn't seem to fit the data at all. It's really more like this percentage increase. I don't know. So that's
okay. So that's super interesting. So thanks for making us aware of that.
Yeah. Well, I wish we had the reference is not going to be ready for some time, but I
see.
In the end, I don't think it's going to be too far away from what you guys end up doing if I eyeballed your numbers. But yeah, I agree. That's a super important issue. We've been grappling with that too. Yeah.
Thanks.
Thank you. Thank you. Thank you both. Wonderful. Thank you. Fascinating.